So there are three reasons why ERCP drainage of the pancreatic duct may fail. And the first is that we simply may not be able to access the papilla or the anastomosis, duodenal stricture, or a patient who has had prior surgery. And we may fail to cannulate the pancreatic duct. And finally, we may fail to place a stent, for example, when you have a non-traversable stricture. And in those instances, the patients are usually sent to surgery for a pancreatic jejunostomy. However, we do have the alternative option of accessing the pancreatic duct under EUS guidance, either transgastrically or transduodenally, usually through the bulb. And we can access this with a standard FNA needle, and we can inject contrast into the pancreatic duct and create a pancreatogram. And I like to call this EAP to emphasize the anterograde approach, contrasted to the retrograde approach of ERCP. So we have accessed the pancreatic duct anterogradely, and now we can pass a wire through our FNA needle. And the first question is whether we can pass that wire into the bowel. And if the answer is yes, then we can proceed to switch out our echo endoscope. It's actually performed its job. We can switch it out for a endoscope, be it a duodenoscope or a push enteroscope, and then we can retrogradely drain the pancreatic duct. And I apologize, I use a Mac, and so some of the things have shifted in the conversion to PowerPoint here. So this is a video showing how sometimes when we cannot reach the anastomosis with the push enteroscope, by just passing a wire into the jejunum, this will assist us in gaining access to the anastomosis. So here we've punctured the pancreatic duct, which is dilated, with a 19-gauge needle, and we inject contrast into the duct. We get a nice pancreatogram, and next we negotiate our wire across the strictured pancreatico-jejunal anastomosis. And we're able to get it into the jejunum, and now we push it as far up into the afferent limb as we can. And this will then assist us when we do push enteroscopy. We just look for the tip of that wire, and once we identify that tip, we're going to pull that wire into our push enteroscope, and we will literally tow the tip of the push enteroscope up to the anastomosis, so it assists us to gain access to the anastomosis. And now in this case, we used a balloon to dilate the strictured pancreatico-jejunostomy. So what is the success rate of the rendezvous procedure? Well, Takao very nicely compiled the literature, total of 75 patients, 12 publications. The technical success rate was 72%, but these are retrospective studies. This is not on an intention to treat basis. In my opinion, the success rate is really below 50%. And why is that? It's because wire manipulation through an FNA needle is difficult. Firstly, there's a lot of friction inside of the needle. But more importantly, that wire easily catches on the sharp tip of the needle. And this can lead to shearing or even transection of the wire. And here you see such a case where the tip of the wire got transected at the tip of that sharp needle. So my tip is, firstly, use a 0.025 VisiGlide from Olympus. This is a great wire because it has the stability and the robustness of a 0.035-inch wire, and use that through a 19-gauge needle. Now, if that fails, then I would switch to a hydrophilic guide wire. All right, so now, if we're not able to pass that wire across the stricture and across the papilla or the anastomosis, well, then we have to resort to direct anterograde drainage. We don't want to leave a duct undrained. And I like to call this EAPD, again to emphasize the anterograde approach to drainage. Now, this was described some time ago in 2002, and we're going to add now 2 additional steps to the Seldinger technique. So we already have a wire in there. So now we just need to dilate the tract and then place our stent. Well, it sounds very simple, very straightforward, but in fact, it's not so easy. And the reason why is because we're usually dealing with a very fibrotic, indurated pancreas. And it's very difficult to pass our instruments over the wire into the pancreatic duct. And this is an example showing where we usually require cautery. So here, sorry, let's go back. Sorry. How do I go back one? Can you go back one, please? The video didn't play. Maybe you can play the video for some reason. Okay, there we go. So the wire, as you can see, is not traversing the stricture, right? So we're not able to go to a rendezvous procedure. And here all we've done is exchange that FNA needle for an ERCP catheter. So this has a 5 French diameter. And you can see how that ERCP catheter, it buckles every time we try to advance it into the pancreatic duct, and that's because of that fibrotic pancreatic parenchyma. So we have to resort to using cautery, and here we're using the 6.5 French diathermic sheath with the diathermic ring at the tip to gain access, and then we can place our pigtail stent. Now the drawback, though, and the concern I always have when I use cautery is that we can produce thermal injury to the pancreas, and we can trigger pancreatitis. So each of these different devices that we can use for tract dilation, they have pros and cons. And in the case of pancreatic duct drainage or dilation, we usually have to resort to cautery, and we have to then weigh that against the risk of pancreatitis. And I personally have had a few patients that experience very severe pancreatitis after using cautery devices. So let's look at the outcomes of EAPD. This is a compilation of 10 published studies, the most recent from 2015. Now, in the interest of time, I'm just going to summarize for you that the overall success rate is only 68%. That means that the procedure failed in 32%. That means 1 out of 3 procedures failed. But more concerning is that there were severe complications in 28% of the patients. And we're talking about perforations and leaks. I mean, these are patients that suffered from severe complications. So low success rate and high complication rate. And let's just look now at the most recent publication. It's the largest study by Dr. Will from Germany. Published last year, 83 patients on an intention to treat basis. Now this was retrospective, but it was a prospectively collected database. The primary success rate was 57%. I should say only 57%. That means the failure rate was 43%, even higher. And of those successes, EAPD was possible in only 55%. So that means only 1/3 of the patients on an intention to treat basis underwent EAPD. There were moderate to severe complications in 25% of the patients, including 1 perforation that required immediate surgery. So I think this gives us some pause about, even though this has been around a while, about whether we should really be doing this procedure. And the question is, why are we seeing these high failure rates? And the answer is, it's simply difficult at all levels. Beginning with access, small diameter duct, we're actually perpendicular, the duct, to the needle. We have the interposed pancreatic parenchyma. The tract dilation is difficult, as we discussed, the need to use cautery. But also the stenting is difficult because we're in the stomach usually, which is capacious, very elastic. Our position is unstable, and we're often tangentially tunneling into the wall. We don't always appreciate that with EUS, just how tangential we are. But more importantly, we often forget that the pancreas is not adherent to the stomach wall. There is the lesser sac interposed between the stomach wall and the pancreas. And we see this in our anatomy textbooks very clearly here. This is the lesser sac interposed between the stomach and the pancreas here. So it is not surprising when you get a leak, that leak will quickly fill into the lesser sac. So to summarize in terms of the pancreatic duct drainage, where are we in terms of EUS application? I would say we face significant technical difficulties with high failure rates, high complication rates, and really in the end we have to ask ourselves, is the benefit Even in those cases where we're successful, is that benefit really worth the risk? We don't have any studies proving that what we're doing offers long-term benefit to the patient. And in the end, are we just buying time to eventual surgery? All right, so now let's switch gears to gallbladder drainage. And the gallbladder is something we always see very nicely, usually from the duodenal bulb. We can also see it from the stomach antrum. It's in direct apposition to the wall, and it often looks like a pseudocyst. In fact, on one occasion, I accidentally drained the gallbladder thinking it was a pseudocyst. So it happens to the best of us. Now, the challenge, though, of gallbladder drainage, in contrast to a pseudocyst, is that it is not adherent to the bowel wall. These are non-adherent lumens, and earlier in the live, I showed you that hyperechoic, that very bright layer that can be interposed between the bowel wall and the cyst wall. So we have the gallbladder here, and we have the duodenum here, and we have that bright layer interposed between. And so there is a risk of perforation and leakage and peritonitis that can be fatal when we attempt to drain the gallbladder. There's been experience using plastic stents to drain the gallbladder, 4-case series with a total of 35 patients, all with acute cholecystitis, all high risk. Great technical success, but there was an 11% complication rate consisting of bile leak and pneumoperitoneum. So definitely here we need a better solution. One proposal was to use a fully covered self-expandable metal stent that certainly can seal off that tract better. You can see here in this report in 65 patients, great technical and functional success rates, but here too we have early complications of perforation and pneumoperitoneum, and we have late complications of stent migration and stent occlusion. So this is not ideal. And so Bertrand asked me to address the question, can we make gallbladder drainage so easy and safe that any endosonographer can do it? Well, I think I'm sorry, I'm not sure why this happened, okay. I think the answer is yes, but there is a big if. And firstly, we have to eliminate two things. We have to eliminate the risk of bile leak. That means we have to eliminate over-the-wire exchanges, because the bile leak can occur during that over-the-wire exchange with these multiple step processes that are required. And of course, we have to seal off the fistula tract. And we also have to eliminate the risk of stent migration. And I dedicated the last 10 years of my life to developing platforms that I thought could allow us to reach these goals of eliminating these two variables. And so the first, and really the more important, is a cautery-enhanced delivery system that allows you to deliver your stent with one device. So it's not really one step, there are multiple steps, but all those steps are combined in one device. So once you puncture your cavity, you can immediately deploy your stent without doing any exchanges over a wire. So it is exchange-free. And the cautery is enabled by using micro wires that are at the very tip of the device and run along the sides. And there's, of course, a dilating bougie-shaped tip to facilitate entry into your target cavity, or the gallbladder in this case. Now, of course, the lumen-opposing metal stent is important to prevent migration. And because the length is limited to the wall, you're going to reduce the risk of any collateral damage, any collateral injury to the opposite walls, the gallbladder wall and the duodenal wall. And the device has to be endosonographer controlled. So the endosonographer must have the ability to control the delivery, the deployment of this device with his or her right hand, completely in his or her control. This is not something that you can delegate to your assistant. And so it should really work like an FNA needle, as you can see it luer locks, and you saw that, of course, in the live demonstrations today. There are separate hubs for sheath advancement and device deployment, so the black hub here and the gray one. So the black hub advances the sheath, and the gray deploys the stent, and it is deployed in two separate steps. independent of one another, so that each flange, the distal and proximal, are deployed independent of each other. So here you can see a case of a decompressed gallbladder. The patient had a cholecystostomy tube placed and wanted to have this internalized. So the gallbladder is actually quite contracted, but we can fill the gallbladder with some fluid through the percutaneous cholecystostomy tube. So even though it's not that large of a gallbladder, we can access it very precisely under ultrasound guidance using the electrocautery enhanced system. We deploy our distal flange, just as you saw many times today, and then we deploy the proximal flange in the duodenal bulb. And you can see then the bile immediately draining. Now in this case, to minimize any risk of any complication, we just left it in place, and that's actually my preference for the gallbladder, not to dilate and go into it. There really isn't a need to do that, but to go back several weeks later, and then usually the stent has expanded on its own, so you don't need to really actively dilate the stent. So you can see at 1 week follow-up, we're able to very easily enter into the gallbladder. And you can see the typical trabeculated surface, sort of a new dimension of the GI tract for us, so the very typical appearance of the gallbladder mucosa, and you can see that cholecystostomy tube in place. And this is the ultrasound view showing the lumen-opposing stent in place with the distal flange in the gallbladder, the proximal in the duodenal bulb, and the saddle in between. This is a publication from 2016, a multicenter trial, also including, mostly in Europe, but also including Dr. Itoi's unit in Japan. 30 patients with acute cholecystitis, all used the hot cautery-enhanced delivery system, high technical and functional success. The median total scope time was only 15 minutes. So I think that's the remarkable thing, that we're really simplifying this and making it much faster. There were no early significant adverse events, no leak, no peritoneum. There were some late SAEs in 50%, in half the patients, but only 13% were possibly related to the stent procedure. And you can see that here, the two stent-related complications, they were related to bleeding. And so this is being investigated, what the source of the bleeding might be. But at any rate, there was no leak or perforation. So in summary, where are we with gallbladder drainage? Is there an application for EUS? And I would say here a resounding yes, but there are three prerequisites that we have to meet for internal gallbladder drainage. And the first is we really have to have a standardized, reproducible method that guarantees high technical success. And this must be leak-proof, absolutely leak-proof, and it should be durable. And so we haven't answered the question of durability yet. That's yet to come. The evolving LAMS technology is very promising to meet these three prerequisites. And I want you to bear in mind that EUS has been around for several decades now. I did my first pseudocyst drainage in 1992, and it was the first EUS-guided pseudocyst drainage. And yet, after more than 20 years, we still have not seen, at least the device companies, develop the sort of tools that we endosonographers need to be able to advance the therapeutic frontier. So this stent and delivery system, the LAMS, is the first device dedicated to the endosonographer to achieve the goals of endosonography-guided therapy. And what I'm really excited about is that maybe now we will see all the device companies come on board and really dedicate the resources that are needed to really push this frontier and to develop more of these types of tools. Well, thank you very much.
Thank you, Kenneth. Talking about very promising devices.
Stay, please.
Ken, please.
Takao and Michael, if you want to come also.
Yes, now we had the 3 lectures about anti-tumor therapy, pancreatic duct drainage, gallbladder drainage, and also bile duct drainage using the EUS.
So it's time for questions.
So, any discussion from the audience? Yes, please.
You said
please. Mic, please.
Dr. Ikoi, I was just wondering, you showed us wonderful data on hepaticogastrostomy with plastic stents. I wonder what if you have to, exchange those stents, or what happens if you have a patency problem with those stents?
Okay, the question is if you insert a plastic stent in hepaticogastrostomy, how do you need to replace it?
Yeah, so in some part I agree with you. So first time I worried about that, just 8 French. But however, when you perform a PTBD, at that time, which size do you use? Usually, 7 or 8 French is commonly used. That's why, basically, the whole biliary dilation, not so comfortable, not so uncomfortable. I guess mostly well drained. However, as you mentioned, as you worried about in the stent occlusion sometime, exactly, so we experience around 3 months stent occlusion. We have just such kind of data. At that time, we remove the stent and put a new plastic stent. And at that time, usually, always we can create the fistula. Fistula is completed. At that maybe 2 weeks, 3 weeks enough.
Are there any anxiety about the leak from the dilation tract?
No, because we never use balloon dilation and for the tract dilation. Just 6 French cystotome and then 8 French stent insertion. The stent is very hard and the torquing and the perpendicular power is so nice. That's why, after the 6 French cautery dilation, they very easily, very smoothly go into. That's why, no leakage alongside the stents.
Okay, I see. Yeah, please.
My question is for Michael Levy. Congratulations for a very nice and clear presentation. So, as we can see yesterday and today, contrast harmonic EUS can be very useful tool for diagnosis of pancreatic mass, and I know you're patient for this tool. Okay. So what do you think about the usefulness of microbubbles in monitoring of antitumoral treatment in the future?
Well, I'm probably the wrong person to ask. I'm not a believer, as you know, in contrast or elastography. I think they're expensive tools that add nothing. I know that's not a popular statement to make, but I think we actually demonstrated over the past couple days how little they added to the care. I think for the most part, the endosonographers fully knew what they were seeing and simply confirmed it or waited for the blue or the green or the whatever to say what they already knew. So I'm not a believer in either one. Might it be helpful in evaluating ongoing therapy after intratumoral therapy? I don't know. I think it's possible. I think there are going to be areas of necrosis and dead tumor that it may help highlight. So maybe that will be a role, but we'll have to see.
Thank you.
Thanks.
And I have a question to Dr. Binmoeller. The main indication for gallbladder drainage is cholecystitis in very ill patients or in patients with advanced malignancy, and the latter group requires the drainage until the end of their life, which is usually several months. And how long can you left in place the axial stent in these patients?
Right. So excellent question. So how long can you leave the axial stent? So in that trial that I showed you from Daisy et al., Daisy Walters, this study required that the axial stent be removed at 3 months. However, it turns out that I think more than 50% of the patients refused to have the axial stent removed. So they had the opportunity to follow these patients, and I think the median follow-up time, it was well over a year. And interestingly, none of these patients developed any complications during that follow-up period. So all of the complications, the SAEs, were observed within that 3-month interval, But after 3 months, none of the patients that had long-term indwelling stents had problems. So it suggests the possibility that these stents, the luminoposing metal stent, could be left in long term. Now the next question though is, what is the length of time that is required to create a durable fistula, even after you remove the stent? So, you know, a mature tract may have formed large enough to enable drainage of the gallbladder on a long-term basis, but we don't have the answer to that yet.
Thank you.
I would like to ask you about the fluid impaction into the gallbladder through the stent. Are there any fluid impaction sometimes in some cases?
I'll let Dr. Itoy answer that question. He's observed that.
Yeah.
Yeah, exactly. So I have some patient, such kind of the food infection, food reflux. But not so serious complication. Of course, some food go into the gallbladder and so comes out spontaneously. Yeah. Maybe sometimes the completely the occlusion occur. At that time, so we have to remove using a standard EGD, like a necrosectomy. Yeah. Yeah, exactly, we experience. Yeah.
Thank you very much. Yes, please.
Yes, so I have another question for Professor Binmoeller. Just a practical question. You have different stent sizes for heart axios. Is there recommendations for the bile duct versus gallbladder in terms of size? And I guess my question too is, how long can you keep them in the bile duct as distinct from the gallbladder? Is there any data about that?
Right, so I honestly can't answer the second part of your question in terms of how long. So right now, you know, I think the recommendation is to remove it after 3 months or potentially replace it with something else. Now, obviously, if it's for palliation and the patient's doing well, then one may decide to simply leave it in. But there is the IFO that recommends that it be removed at 3 months. Now, I think the other question that is very relevant is, how do you select the size of stent to use? And here it depends on two variables. So firstly, the diameter of the cavity that you're draining. And I mentioned today that pseudocysts are, for the most part, what we're draining, they should be, you know, no less than really 6 centimeters. Otherwise, you might question whether the pseudocyst, unless it's infected and causing symptoms, is really the cause of the patient's symptoms. So you should use a 15 millimeter for all pancreatic fluid collections. For the gallbladder, you could use a 15 if the goal were to remove some large stones and you needed a larger diameter. The gallbladder is pretty capacious, but for the most part, we use 10 millimeter for the gallbladder. Now, the bile duct is the part that gets tricky, but often patients have a significantly dilated bile duct. You saw such a beautiful example that Dr. Itoy showed you that, you know, almost was the size of looked like the gallbladder, and you could clearly use a 10 millimeter there. But the axial stent does come in smaller sizes of 8 millimeter and 6 millimeter. So that's the diameter, but what also differs is the length of the saddle. So you have saddle lengths that are shorter. 1 centimeter is the longest. So again, you want to customize and sort of select the diameter and the saddle length based on the local anatomy that you're dealing with.
Two questions. First, just behind that, Ken, I'm here. It concerns the biliary drainage. When the common bile duct is not so large, around 10-12 millimeter, don't you think that we should systematically insert a guide wire to secure the position and to help the catheter to be really inside the...
Yes, so the answer is, and I do that, but what I do is I preload the delivery system with the guide wire. So the guide wire is just shy from the tip. So once I'm inside of the bile duct, then I advance the guide wire forward. I also do this for gastrojejunoscopies, the same, because it's very important there to have sort of a safety net. So you advance your guide wire forward, and then you deploy the stent, knowing that, you know, if there's, first of all, that will give you the right axis, but also if anything should go wrong, you always have sort of a safety net with that guide wire in place. But you're not doing an FNA first and placing a guide wire and then using the electrocautery to gain access, but rather you're using it freestyle, meaning you go in with like an FNA needle, with electrocautery, and then you simply advance your guide wire forward as soon as you're in the duct.
Okay, thank you. Michael, one question. Do you have any experience about radio frequency in the pancreas with the needle or star med?
You know, I've only done, I think, 4 or 5 patients with radiofrequency ablation. 2 of the lesions completely resolved, functioning neuroendocrine tumor, a met from, I think, the kidney, completely gone on subsequent imaging. The one I showed that I may have caused needle track seeding, and another one that I've actually treated twice that hasn't changed in the slightest. It's enhancing just as much as it used to. I was clearly in the middle of the lesion, treated appropriately. I was wondering if the device even worked. 2 therapies, same patient, absolutely no change. So kind of 2 good, 1 worrisome, 1 no different.
But no major complication?
No
with
complications.
pancreatitis. Okay. That's
Other than maybe the needle track seeding.
Yeah, we have a trial currently in France we are conducted about that with now 16 patients included, and we were surprised to have no pancreatitis, no severe pancreatitis for the moment. So perhaps for the future it should be a trade.
Question?
Yeah, please.
Yeah. This is a question for Kenneth. Kenneth, well, first of all, congratulations, because I know you since you started with this idea, and I see that you're getting there. But the question maybe is difficult for you to answer, because you just said that you start more than 20 years ago, you did your first drainage, right? So you know what's been happening in these 20 years, and you have this idea for such a long time. So why do you think it's taking so long in our history to get these devices? Do you have an answer? Do you think why it's happening? Is this impossible, or is just that somebody's waiting? What's happening?
I alluded to it at the very end of my talk as a sort of an editorial comment, and that is that the device industries have not given it priority. And it really relates to the market size. So they haven't perceived EUS guided intervention and therapy as really a sufficient priority to make an investment in, because the number of endosonographers performing therapeutic procedures was perceived as being very limited. That's obviously changing, and we see that here with the attendance of this symposium, but at many, many symposia around the world that now are exclusively addressing EUS guided intervention. So this is obviously changing, and I think we're going to see many more developments like this now that industry has this on their radar.
You know, I think that this is happening because this time there were too little people that perform ERCP and EUS. Now, most people that perform ERCP perform EUS. Like Dr. Itai said, his balance was for ERCP, but he's doing EUS. So I think this is the answer. That most ERCP people perform EUS, this is going to get better.
Okay, Marcin, the last question, please.
Very quick one. Dr. Binmoeller, the device penetrates so easy the cavity, the GI wall and the cavity. So it makes me wonder whether there is a risk that it also can penetrate the opposite wall if you stop using cautery in the right moment. Is it possible to penetrate, perforate, or well, to make a hole in the opposite wall of the cyst or whatever is being drained?
Yes, absolutely. And so that's why you need to do this under complete ultrasound guidance. You need to see where the tip of the sheath is, and you need to be able to control very precisely how deep you're inserting it. But, you know, it's not a thrust. It's a very gentle, with your burn, the cautery enables you to go in very slowly, really. And hopefully it was demonstrated for you at this meeting. You don't have to push. And so you can control your sheath very precisely so that this doesn't happen. But absolutely, you could go right through the opposite wall if you continue to give cautery.
I have one question to Michael. During the radiofrequency, you found the needle track seating. Usually we perform the USFNA using 90 gauge needle. We don't have so frequently have the needle track seating. If we perform only the taking samples, but during the radiofrequency, why such kind of the needle traction happens? Do you estimate what the mechanism about it?
Yeah, honest answer is I don't know. I'm not sure why radiofrequency ablation would be more prone to needle track seeding You know, maybe you're stirring up the cells, and as you pull the needle out, you're more inclined to pull those out, but you'd think you would do that with EUS. I do suspect needle track seeding is more common with FNA than we appreciate, but the patient ends up unfortunately dying a few months later. You don't know if it's residual disease or needle track seeding. And maybe that's less likely to occur with chemotherapy, because when you pull the needle out, the alcohol and chemo probably follows the same track. That's theoretical. I'm not sure. I think we need more data.
Thank you.
Thanks all for this very nice overview about interventional EUS today. Thank you. And now I will call Pierre Dupré.